ultrasound can tell you whether there is the intramural gas, or it will also tell you whether the gas is there in the portal vein or in the. So it gives us an excellent bedside tool to pick up NNEC, and also to decide on how to start feeding and how the bowel states and all that. So it's a very good upcoming tool for diagnosing and monitoring NNEC. Those days we used to take repeated X-rays in these babies and look for sentinel loops and all these things. And for that, we have to get the radiologist to come, I mean, a radiographer to come get the X-ray. Then, of course, those who have digital X-rays, fine, they can develop it in the NICU itself. But those who don't have, we have to go down and develop the film and come back, and all these things are there. So ultrasound is a very excellent tool now to make a very quick diagnosis regarding NNEC and also to follow it up. And I think today Prashant sir is going to give us a detailed description of that, and that is going to be the key point in this today's class. And of course, all the other important tips we need to know about neonatal abdominal ultrasound will be delivered today. And I think I'll hand over the session to Prashant sir for further progress of the class. And I would like to also thank our Professor Dinakar sir, and I hope he's around for his
yes, sir.
untiring effort to get these classes going on. And thank you, sir. And so without much delay, I think I'll hand over to Dr. Prashant sir.
Yeah. Thank you, sir.
Thank you, sir.
First of all, thank you, sir. Thank you, sir. Thank you, Dinakar, sir. And thank you, Kamal, sir. First of all, I would like to thank for the opportunity for NNF Tamil Nadu, Kamal, sir, and Lakshmi, madam, Rema, madam, and our Vaideshwaran. Thank you for the opportunity. So today's class, it's going to be very interesting. How we can, and today's class is joined by a person who has actually challenged the bell staging. So I will introduce that person very shortly. So he has written an article as well regarding this. So today's class, it's going to be very interesting because how ultrasound abdomen can change the whole perspective, whole texture of management of NEC. And at the end of today's session, I'm very sure that you'll be very much convinced that beyond doubts that ultrasound abdomen is one of the most important thing for neonatologists to know, because of the because we are managing NEC. So in that perspective, today's talk, let us start. So I'm going to play one small video how this exactly happens and each and every stage. So I'm taking you through the walls of intestine, what exactly is seen there and what exactly pathogenesis happens for this. This is a quick video. So how exactly it looks. So when you go through microscopically, this is how the villi and intestinal pathologic cross section looks like microscopically. So these are the villi. You have epithelial cells, you have blood vessels, you have layers of epithelium from mucosal and air interface, then mucosa, submucosa, muscularis. Then you have serosa. These are the layers. So once the bacteria is presented in front of the villi within the lumen, so this will present in front of the villi, and it could be hospital based or it could be any sort of infection and sepsis, because the most common cause of NEC is infection. One of the most common causes. So premature death because of So what happens is premature guts usually it slows down. There is peristalsis which decreases, and the retained food acts like a rich source for bacterial multiplication. So this increases the multiplication and causes rapid reproduction of harmful bacteria, which will increase in number and which will be presented in front of the intestinal mucosa. So this will lead to a gas forming, this will trigger the inflammation mediators. So where you see hyperemia of the intestinal mucosal, interintestinal thickness of the wall, bowel wall. and which will lead to gas forming bacteria producing gas bubble within the intestinal lumen. So this bubble will start dilating the intestinal loop. That is the point where X-ray, if the dilated bubble loops are present, that's a point where both the small intestine, which starts dilating, then large intestine, even that colon, which also starts dilating. So this is the point where X-ray will, we try to pick up from the X-ray. So why I'm showing this particular video is at every stage when it is progressing with ultrasound abdomen, you can actually anticipate, you can see live, real time, and you can actually prevent by appropriate measures. So you will not have any confusion in terms of understanding this. So this is exactly how it looks, and this is the point where you start noticing in X-ray. If it's early trigger stage, biochemical markers which will help, but there are which we do biochemical markers are not that specific. I'll show the evidence as well. So once this starts, the gas distension increases, which will lead to decreased, elevation of diaphragm and restriction of the lung expansion. So which might lead to acidosis because of lack of oxygenation. So now once the gas is too much, and still if you're confused, and still if you don't take an appropriate measure, it starts leaking into the intestinal wall, goes into the muscularis layer, and where you start seeing the thing, and this will lead to this gas bubble will start moving into the portal venous system, drained into the portal venous system, and where you start seeing the portal gas bubbling. So even in ultrasound, this particular movement of gas bubble into the portal vein, into the hepatic vein can be seen very clearly. So that's why every stage of pathogenesis, you don't have to look into the X-ray and search for that pneumatosis intestinal lysis. If you use an ultrasound probe, you will see beautifully how exactly it looks, and you will know. So even this movement of gas bubbles within the portal gas can be seen, and then that is the point where ultrasound is quite sensitive, and it is 100% specific. A lot of studies which has been done in last 10 to 15 years regarding this. So in X-ray, you might have confusion till it reaches the most advanced cases. So that's why if you know the pathogenesis, you will understand at stage of pathogenesis progression, pathological progression, you'll be able to pick it up. So this is how exactly it looks like, portal venous gas. You're literally, you have to take an X-ray, take a nice X-ray, go near and look at the portal gas. When it comes to ultrasound, I'll show you, unless you're blind, you will not miss the pneumatosis intestinal lysis and portal venous gas. So all this gaseous distension will obviously lead to ischemia, because it starts blocking the capillaries and the blood vessels within the lumen, which will start causing ischemia to the bowel wall, which will lead to perforation starts appearing if you don't treat even at this stage. And then once perforation happens, the inflammation sets in within the peritoneal cavity. You try to contain within the peritoneal cavity. Still, if you don't take any action, it will lead to perforation through the peritoneal cavity into the abdominal cavity with free fluid. So free fluid being one of the most sensitive marker in terms of predicting the outcome, surgical outcome, whether surgery needs to be done or not. So free fluid is one of the sensitive marker. So this is exactly what happens. So now the leakage has happened into the peritoneum. Now from there it starts moving into the peritoneal abdominal cavity. This is how it looks like, where the gas and bacteria, gas into the diaphragm, gas and in the peritoneal cavity, and some perforation into the abdominal cavity. So this is the brief introduction which I wanted to give, and give an idea that what exactly happens within the baby's tummy when NEC is happening. These are the processes which pathogenesis which exactly is happening. So we as a neonatologist, with the ultrasound, you can actually see the every stage. So you can intervene quickly. You don't have any confusion. You can actually guide the pediatric surgeon when to act. If you don't do it, all this septicemia sets in, wherein the bacteria starts entering into the systemic circulation, into the entire body, and it will be too late by this stage to save the baby, where mortality will be very, very high at this particular stage, where entire septicemia is set in and difficult to save the baby. Now we'll move on to the next one. So this is the study which I was talking about. This is the author whom I was talking about, who had challenged the Bell staging with X-ray and management. So please read this article. It's a very beautiful article written by none other than our Dinakar sir, who has written very, very beautifully. And he has compared every clinical findings and X-ray findings with abdominal ultrasound finding. So kindly note the name of the article, or just type Dr. Dinakar Prithviraj in Google about a comparison between the X-ray and ultrasound abdomen. You'll get this article. This article is freely available. You don't have to pay for this. Now let us enter into the ultrasound of abdomen. What are the things which you need to know when you are planning to do an ultrasound abdomen? You need to have anatomy is the most important thing before you do the ultrasound. So anatomy of the bowel, pathologically cut section wise how it looks, colon, jejunum and your ileum, which plays important thing. Then ultrasound patterns and markers in NEC, which we need to know. So this is how the blood supply is. You have your superior mesenteric artery, inferior, inferior mesenteric artery, you have colic arteries, right colic artery, middle colic artery, ileocolic artery, jejunal and ileal branches. Watershed area where dual supply of the blood happens with that particular thing. Even if there is blockage in one particular blood supply, when there is watershed areas, dual supply happens and it maintains the perfusion and it prevents the ischemia. So normal intestine, how it looks, it's a layer. We know that from inside to outside. If you take, there is a mucosal and air interface. Then you have mucosa, you have submucosa, you have muscularis propria, and you have serosa. So from outside to inside, if you come, serosa, muscularis layer, you have submucosa, mucosa, and the mucosal air interface. So always remember in ultrasound, whenever there is air and mucosa, that particular, we call it as mucosal interface, that will always be echogenic, that is white in color. Wherever blood vessels are there, blood is there, that will always be black in color. Wherever air is there, it will always be white in color. These are the few basic things which you need to remember. So normal intestine will have a layered appearance. We call it a signature of the intestine, easily compressible. So if you put a probe, if you press the probe, you will see the bowel loops, easily compressed and it easily gets displaced. And you see nice compression and expand, peristalsis of intestinal loop, which goes like this. If you close your fist and then if you open, again if you close, if you open, this is how exactly a nice peristalsis you see. That's a good thing. And then we can measure the thickness of the bowel, whether there is thickness has increased, whether thinness has happened. So these are the few basic things which you need to remember before we get into the ultrasound abdomen. So now anatomic location, we know that jejunum is upper half of the abdomen and ileum is the lower half of the abdomen. And how exactly it looks? See, if you look at the jejunum, you can see here, one second, I'll just see. So which I'm talking about is all this mucosal folds, which you can see here. We call this as plica circularis. So in ultrasound abdomen, I'll play you the video. You will see this plica circularis in the ultrasound abdomen. If you go with the ileum, the graph of the ileum, which you can see here, it's quite smooth. That means the inside you don't see the any mucosal folds. You can see here, so you can see the layer. This is your mucosal interface. Then you have your mucosa. Then you have your submucosa. Then you have your muscularis propria, and you have your serosa. This is called intestinal signature, which I'll show you again. So these are all your stools. If any worms are there, you can see the worms movement here. So while doing an ultrasound, before we enter into ultrasound, these are the basic things which you need to know. We have to identify what is jejunum, which part is ileum. All right, so now we'll move on to the next video. I'll show you how it looks. You can see now how jejunum looks, plica circularis looks with this. So you can see the muscularis folds here. See, if you take this, you can see here, this is one loop. Okay, right? You have put a probe here. You have put a linear high frequency probe. And then you have your layers of skin, abdominal layers. Then you have your peritoneum. Then you have your liver. Then you have your intestine. So here you can see in the transfer section how the plica circularis looks. So we'll play the video again. See how it looks. So you can see the peristaltic movement. Now, ileum I have showed you how it looks. Now coming to the colon. So in colon, we know that colon is a bigger loop, and you have your haustra like this, where you can see this. Colon haustra. So even in ultrasound abdomen, you'll be able to appreciate this. So let us play the. Sorry. Yeah. So let us play the video. So here we have put a probe. Then you know how exactly it looks. You can see this is a small intestine which we are showing, and the finger is marking the nematosis intestinal layer, not in the muscular layer. It is inside the lumen. You can see the movement, how it looks. So if you have a high frequency probe, you can beautifully see. The layers of intestine, which will also give an idea with the linear high frequency probe. So this is how exactly it looks. Just to give an idea how exactly the bubble looks. So plica circularis jejunum, then you have your ileum, then you have your colon. So in X-ray, there are only three things which you look at. One, nematosis intestinalis, portal venous gas, perforation, and dilated bowel loops, which is non-specific. You won't be able to differentiate large bowel dilatation versus small bowel dilatation because all the image gets jammed. And even if you want to look at the thickness, since multiple intestine is overlapping, you won't be able to get an exact idea when you do an ultrasound, when you do an X-ray, sorry. So confusion with well staging, stage 1, it is limited to mucosal injury, which I have shown you the pathogenesis. You always get confused with sepsis. In stage 2, with progressive injury, again you get confused. In stage 3, it will be too late. So with X-ray, if you go, it is always undertreated or overtreated or misdiagnosed. I'm sure you have experienced it because of this poor sensitivity. So alternatively, we try to do with biochemical markers, like we do CRP, we do certain newer biochemical markers which has come. But if you take CRP also, in all stages of well staging, a study was conducted which clearly showed evidence that there is no much change in CRP along with biochemical markers, which would guide you in terms of deciding either going for the medical management or going for the surgical management. So this is again clinical parameters. If you see a clinical parameter here in this graph, see here the green is representing the medical management of NEC and red is representing the surgical management. If you see here, 40% of them before it became medical versus surgical, it's almost symptoms are same. That means even with clinical picture, it is very, very difficult for you to decide on either going for medical management or going with the surgical management. That's why if you have ultrasound, it will be easy for you to decide how to go about. So we had 3 or 4 pictures, 4 signs we saw in X-ray. Now coming to ultrasound, you have 12 features. One is you can see free air, oral air, nothing but nematosis intestinalis. So one is your free air, Mural layer, nothing but pneumatosis, intestinal lysis, complex fluid, exudative fluid, peritoneal fluid, portal venous gas. Then you have your thickened bowel. Then you have your thin bowel. Then you have your peristalsis, nice peristalsis 10 times per minute. You have your intestinal signature, nothing but layers of intestine which you can see. And then coming to color. So even in color also, you might see different patterns like, circular pattern, zebra pattern, Y-shaped pattern, or absent of color flow. And you can also check the supramesenteric artery diameter. That also it should be between this and this. It should not be more or less. And then the velocity. So many features you have got with your 2D ultrasound. With Doppler, if you add, there are 12 features. Whereas in X-ray, you had only 3 pictures. So that's what, unless you are blind, you will not miss it. Obviously, you're looking at the superficial structure and you're seeing the neonatal abdomen. That's why high frequency, where you can see the picture very clearly of the near objects. So we advise you to use high frequency, high resolution, either linear or curved, whichever you have, you can use, and you can perform the ultrasound. So you need to do all the 3 things. Your 2D ultrasound, you can go with your color Doppler and check for the supramesenteric artery diameter and velocity. You can start with your right iliac fossa, move to right hypochondrium, and left iliac fossa, or you can do like this. Start from here like a snake, go like this, go like this, go like this, and like this. So this way also can be done. Ultrasound, or quadrant wise also you can do. So you can decide how you want to do it and how you are comfortable with. The first major advantage of ultrasound in NEC is you can visualize the bowel wall directly. That means the health status of the bowel wall. What is the first stage where mucosal alteration happens? And you can assess the bowel thickness, echogenicity, peristalsis, how beautifully it is moving. So ultrasound has got very good advantage. So this is what I was talking about. Now, can anybody tell me, unmute and tell me, this is the layer. So this is jejunum or ileum. What is it? Second picture. Jejunum means you have plica circularis. Ileum means the inside will be smooth. Can anybody unmute and tell me which I have ticked? Jejunum or ileum? Sorry?
Ileum.
Ileum, correct, because there is no plica circularis. The inside is very smooth. If you take this particular thing, and if you see, this is the first one is your mucosal and your intestinal mucosal and your lumen interface. That is always white in color. Clear? Next you get your mucosa. Mucosa has got blood vessels. That's why it is hypoechoic. This is echogenic, this is hypoechoic. Then you have your submucosa, again it is echogenic. Then you have muscularis, there again blood vessel is there, so it is hypoechoic. And serosa, again it is echogenic. So it is like this. So only 2 layers. One is mucosa, which is hypoechoic, and musculosa or muscularis, which is hypoechoic. Rest all is echoic. So this particular pattern is called as intestinal signature. So in pathogenesis, I've shown you in the first video what exactly happens. All these villi will get destroyed. Then the intestinal bacteria will start producing gas, causes distension, and this gas will break through the mucosa and then enter into your muscular layer, muscularis, musculosa. So this is how it happens. So basically this intestinal structure will get altered. So you won't see this nice intestinal separation, layers of separation. So this will be altered. Now in transverse section, if you take transverse and longitudinal section, I have put both the pathological slide versus the ultrasound thing. See, you can see here what has happened? Can you see any intestinal architecture signature here? Can you unmute and tell me? Can you see any intestinal architecture? I'm just marking the bubble loops. So this is your.
No, sir.
No, it's not.
Not clear, sir.
Very beautifully the layers of the intestine. Now it is all altered. So that's why this layer will be altered. What we call it as intestinal signature will be altered when inflammation sets in, and which will lead to loss of intestinal signature. So this is your transverse section. This is your longitudinal section. Here also you can see nicely all different layers of your intestine if you go with the longitudinal section. So this is the healthy one and this is the necrotic one. You can see what has exactly happened with the mucosa. See, all the healthy mucosal villi is lost. So in direct, if you do a laparotomy and see necrotic bubble loop. Now coming to the thickness. So now can anybody tell me first picture whether it is jejunum or ileum? This particular loop. What is it? Can anybody unmute and tell me whether it is jejunum or ileum? Can anybody tell me?
Ileum.
Ileum, sir. Ileum, sir. Ileum, sir.
See, ileum will be very smooth, correct? There won't be any plica circularis. 1 second. See here. Okay. See, this is your ileum. Can you see the ileal loop here? Clear? Can you see your jejunum loop here? How it looks? I'll play the video again because I want you to know this. This is very easy. 1 second. So this is how your jejunum looks. Can you see? How your jejunum looks with plica circularis. Now, I have few more videos. I'll show you. You'll be able to differentiate. All right. So this is your jejunum. So here we have tried to check at the thickness of the. There's the pen. Yeah, we have tried to check the thickness of the loop. So initially there will be thickening. Then once the ischemia sets in, then you start noticing the thinning of the bowel wall, bowel loop, bowel wall. You see here, so you can see here, it is completely dilated and it is very thin. So what is the measurement? 1.3 to 2.6. Anything more than 2.6 is thickening, less than 1 mm is your thinning. So we have learned one important thing. One is the intestinal structure, signature, thickness and thinness. So these are the few things you can see here in this particular bowel lobe. What has happened is intestinal architecture is gone, signature is gone. You can't differentiate. Plus thickness also has increased. So here you can see there is thinning of the intestinal wall. Again, signature is lost. You can see here. This is your one bowel loop. So this is your second bowel loop. You have your third bowel loop. And can you tell me whether it is ileum or jejunum? This one, third figure. Ileum, correct. So you can see here again there is thinning about to perforate. You can see here thinning and about to perforate. So the red dots, what you are seeing here is your air bubble within the lumen. So sometimes you might get confused. How to differentiate also I'll tell you in the upcoming slide. So intestinal loss of intestinal architecture, thickening and thinning, I'm sure you got an idea how exactly it looks. So again, bowel wall thinning and complex peritoneal fluid. So here I have shown both. One, your bowel wall thinning, you can see here. Your intestinal signature is lost. It has become thin. You can see a free air here. Sometimes you start noticing a septae. See here, you can see a septae here. This is exudative fluid within the peritoneal cavity. It will be very dirty looking, echo dense thing. And you can see here your pneumatosis intestinalis, how exactly it looks. This is one bowel loop. So you can see here pneumatosis intestinalis. Here, I'll show you again. There are a lot of slides are there. Thinning, and this is your peritoneal cavity where gas, free fluid can also be seen. Now I'll play you the video. So pitfalls between pneumatosis intestinalis with absent or ineffective peristalsis and artifact plus peristalsis. So on one side you have a normal looking bowel that is on the right side. On the left side we can see there is no peristalsis. See on the right side where my hand is moving. I'll show you again in the. See, look at this movements. Easily gets, and here you see very sluggish, very sluggish, very sluggish movement. So you don't see that proper punching in and punching out, of the intestine. The peristalsis is lost, and plus in pneumatosis intestinalis, if it's inside the lumen, if you compress, it gets displaced. If suppose if it is in the muscularis layer, even if you compress also, it won't change. So luminal air versus massive intestinal pneumatosis intestinalis. So here in the first picture, I have shown you. So you have placed a probe. This is your abdominal wall. This part is your abdominal wall. Then you enter the abdominal cavity. Then you enter your peritoneal cavity. So this is the one part of the loop, one loop. We see this is marked as your intestinalis pneumatosis intestinalis, nothing but mural layer. And here you can see how it is organized in each and every bowel loop. And you can see a reverberation, an artifact here. So even when there is calcification, this artifact will be missing. So in pneumatosis intestinalis, you see this is how the pneumatosis intestinalis looks. Suppose if you take an X-ray, you have to put a probe and you won't miss this. There you have to literally search. So this is again another picture where I have shown you. This is one loop. Okay, this is one loop of intestine. Yeah. So this is one loop. Yeah, this is one loop, and you can see the lumen. L I have written. This is your air in the lumen. So when you put compress with your probe, so what happens is with your probe, if you compress, this will get displaced. Whereas here, where air which is there in the mucosal layer won't get displaced. So that is one of the key how you can actually differentiate between the luminal air versus the intramural air, the pitfalls which I'm talking about. So now calcification. So I've told you this is calcific. One side you have your calcification, another side you have pneumatosis interstillalis. So reverberation you see, and you don't see that with your calcification. How to differentiate pneumatosis interstillalis versus interluminal gas? I've told you. When peristalsis happen, when you put pressure, when you change the position, the luminal air get displaced, whereas pneumatosis interstillalis will remain unchanged. So now, can anybody tell me, looking at this X-ray, I've posted an X-ray here. So this is the liver. Can anybody unmute and tell me what I'm trying to show? So you have a few bubble loops also you are seeing here. What I'm trying to see?
The portal vein gas.
Here you can see here portal vein gas. Correct? If you have not seen earlier, it is very difficult and you will easily miss it with X-ray. No problem. One second. Yeah. So portal vein detection, echogenic dot, small to 1 mm, slow, fast, intermittent flow, few in numbers. Now I will show you. When you put a probe over the liver, you will not miss. You can see numerous this see all these white dots. What you are seeing is all is your air, which is there in the portal vein, which has gone into the hepatic vein. Can you see here? So there you have to literally search and you have to keenly see the X-ray. If X-ray quality is not good, again difficult. But here, when you put a probe, you will not miss it unless you are blind. Even if you are color blind also, you will see, because it is white and black. So it can be in any pattern, punctate pattern, linear pattern, which I showed you. So one more thing which you should remember is there was one more study which was done, which they were comparing with the outcome. Disappearance of portal venous gas or free fluid is not a marker of recovery. So, or doesn't mean that their clinical improvement is happening. So that you have to remember, especially in the X-ray when you are looking at it. So when it comes to portal venous gas, you put a probe over the liver and try to look at the portal vein and try to look at the hepatic veins. You will see all this, and the best part is even you can see the air bubbling into the hepatic vein like this. And if you put a Doppler here, you can actually hear the crackling sound, noise crackling sound. So basically you will be real time seeing how exactly it looks. So see portal venous gas, which we are talking about, unless you are blind, you will not miss it. Even if you are color blind also, you will see. Now, yeah. So these are the few pictures which I have put now, just to give an idea how the portal venous gas can appear from initial stage to most advanced stages. Few of the things you can see here. See here how you can see here, and you can see this part. You can see here. Okay, so you can see this bubble. Actually, in real time, you can see all this. It's not that difficult. You just put a probe and watch. See here, you not miss it unless you are totally blind. It could be punctate linear pattern, and you can hear the crackling sound also when you put a Doppler. So these are the few pictures which I have put. How exactly it looks. Now coming to the abdominal fluid. So we have seen in the pathophysiology, if the early stage itself, if you are not if you are not identifying the NEC, which can lead to inflammatory mediatory trigger and then formation of free fluid, perforation into the peritoneal cavity, into the abdominal cavity. So the thing is, whenever small amount of fluid is usually normally seen, You don't have to worry. Echogenic fluid between the loops and pouches, I've told you exudate, dirty looking. So you can think of perforation. Abscess, center it might be hypoechoic, in a periphery it might be hypoechoic, and central it might be echogenic. So NEC versus spontaneous perforation and meconium. So second major advantage of this particular ultrasound is we can see what type of fluid which is there. In intraluminal or extraluminal, that is within the peritoneal cavity or outside within the abdominal cavity. So that is the second most important advantage. So which I was talking about. See, now this is your abdominal layer. You have put a probe, linear probe. This is the layer of abdomen, and this is the peritoneal cavity. You can see here, all these things is your exudate, and you can see air also here. This is your lumen. This is your loculated septal fluid. So it looks dirty. Now here also you can see outside in between the lumen, you start noticing the fluid with exudate. So can anybody tell me this particular loop is jejunum or ileum? What is it? Jejunum or ileum, this loop?
Jejunum.
Right. So you are able to appreciate, see here, fluid, septate. So you can see how exactly it looks. So free abdominal gas enters surface of liver. How to detect free gas in peritoneum? You start seeing bubbles also within the fluid. One second. Yeah. So now that's what you can go with the transverse section or longitudinal section, and looking at the one is intestinal signature. Then you started measuring the intestinal thickness. Then you started looking at the pneumatosis intestinal lysis within the muscular layer, air within the lumen, how to differentiate both, how to differentiate pneumatosis intestinal lysis versus calcification when it happens, how to detect exudative fluid from transudative fluid. Exudate fluid will be echogenic with septi, loculation, dirty looking thing within the peritoneal cavity, outside peritoneal cavity, gas, air, if there is any perforation, even bubbling, portal venous gas. So all these things we have identified now. Now coming to the color Doppler. This is also very important. So when you put color to the intestinal loop, you will start noticing in one square, you will start noticing around 1 to 9 color dots. Suppose if it is an abnormal thing, you start having different shapes like Y shape, zebra shape, longitudinal, circular shape. All these things you will see. Now, so first one, I have put 4 picture now. This is your first one, where in one square you are seeing few dots, around 1 to 9 or up to 10 dots you can see within the intestinal loop. Second one, you started noticing a circular pattern. You can see the circular pattern. This is abnormal. You start noticing the Y-shaped pattern. This is abnormal. You start noticing the zebra pattern, the fourth picture, which is abnormal. So the normal is just the dots. Abnormal is you'll have all this pattern. Suppose if you don't have any Doppler, intestinal structure is altered, clinically baby has NEC. That means it has gone into ischemia, which is about to perforate. So bowel wall thickness with increased perfusion in transverse and tangential view. If you are getting all these abnormal patterns, Y sign, circular sign, see Y pattern, I'm sure you're able to appreciate what I'm trying to show you. See here, all these patterns are abnormal. So see here, that is zebra pattern. Can anybody tell me this is jejunum or ileum?
Jejunum.
Very good.
Jejunum, sir.
Put a Doppler. See, you start seeing zebra pattern, which is again, which is abnormal. You can see here clearly differentiate. See here, this particular bowel loop, you are not having any color appearance over here. So you can see pneumatosis intestinal lysis, which is there in the intramural area. intestinal architecture is altered. In C, the intestinal mucosa is totally unhealthy. You can see it is irregular. And you can see here, almost it is very, very thin. That means it's about to perforate. You can't wait. So intraoperative photograph, you can see here, there is thinning which has happened. You can see a gangrenous bowel loop. So if you're waiting with your X-ray with just dilated bowel loop and waiting the baby to perforate, you are not helping the baby. So that's the point where ultrasound will give you a clear picture about what stage of pathogenesis of NEC it is in, and it will give you a clear idea for the surgeon. Now I've compared all the things with the bowel loop. So this is the bowel loop, normal looking bowel loop. You can see here the thickness of bowel loop has gone up. Then you can see hypoperfusion. Then you start noticing the thinness, and then it is almost impending perforation. So respective photograph I have put here. You can see here. Respective photograph I have put here with the pathology, how the perforation happens, and if you don't detect things. So normal thickness of bowel loop, you agree here. And even pattern also, if you count around 9 to 10 dots in each bowel loop, you can see. In the second one, there is thickening, hyperemia, inflammation process has triggered. You can see circular pattern of color Doppler. In third one, there is thick bowel loop is there. See, you can see here, this is the lumen. So this much thickness is there. This much thickness is there. If you take this bowel loop also, it's totally gone. And you don't see any color dot. That means ischemia is setting in. Then you can see here in this very, very thin, the thinning of the bowel loop which has happened, and with color Doppler almost negligible. Can you see here? It has become very, very thin. Third one, impending perforation. It can perforate any time. So this is exactly how the color Doppler and thickness. Coming to the SMA diameter, 2.7 to 3.7 is normal. Velocity of 57 centimeter and should not be more than 120 centimeter per second. Velocity increases in NEC. Less than 1, more than 2.6. Less than 1, immediately call surgeon and you have to operate because it is impending perforation. You cannot wait. Increased bowel wall echogenicity, thick bowel wall, free echogenic fluid, absent peristalsis, these are all markers. So there are a lot of studies which has been done on these parameters to predict the outcome. So if you're able to appreciate all this in your ultrasound, see bowel wall thinning and complex fluid. See here, this is your abdomen. You have put a probe here. So you put a linear probe here, high frequency linear probe. Then you start seeing skin, layer of abdomen. Then you have your abdominal cavity. Then you enter your peritoneal cavity. So this is your one loop. Can anybody tell me this is jejunum or ileum? What is it?
Ileum.
Very good. So if you start noticing a haustra like this within the lumen, then what it is?
Colon.
Very good. So here you can see first thing, intestinal architecture is gone. Then you can see pneumatosis intestinal lysis. You can see thinning of bowel. One side there is thickness, on the other side thinning is there. Then you can see your exudative dirty fluid. You have your air, you have your fluid, exudative. Here also you can see exudative fluid. So this is how exactly the this one looks like. So perfused, necrotic, non-perfused bowel loops also you can see, or you can have different pattern in NEC. Poor outcome indicator arranged in decreasing order, dilated bowel loop with anechoic content, absent peristalsis, echogenic free fluid, absent bowel perfusion, and free intraperitoneal gas. These are all with poor outcome. Take home message: first major advantage of abdominal ultrasound compared to abdominal X-ray is the ability to see the abdominal fluid, whether it is inside lumen, outside lumen, whether it is free in the peritoneal cavity, or it is localized or in abdominal cavity. Second major advantage, you will be able to visualize the health of the bowel wall, whether there is thickening, thinning, echogenic, peristalsis, any air within the bowel. Third and most important advantage is ability to directly see the perfusion, whether it is hyperemic or absence of perfusion is there, ischemia set in, plus I'll be able to see different patterns. So which you won't be able to see with your X-ray. I'm sure you might be wondering, even when I started doing this, I said why I didn't do this early. I could have, helped so many babies with ultrasound probe. So the lot of studies which has been done in terms of comparing. So what are the advantages you'll have? Will be most appropriate to reinitiate the feed, advance the feeding, and you will be able to differentiate between the recurrent NEC versus other causes of bowel distension, and you can pick up the cases early of feeding intolerance, or you can pick up the cases for sometimes, most of the time, pediatric surgeon when they come, they look at the X-ray. You will try to hear the bowel peristaltic movement, and then you'll see a nicely distended abdomen. But in X-ray there are no signs of perforation. So they will tell we'll wait. But if you put up probe, we'll come to know. That's why we're going to discuss now case. I want all the audience, please one by one they can unmute and give their opinion. This is the first case. You have a 28-weeker preterm baby with corrected gestation of 30 weeks now. Does developed abdominal distension, coffee ground aspirate on mechanical ventilation, failed extubation due to apneas. Acceptable blood gas, lactate of 1.6, CRP of 8, total count of 8,600, platelet of 1.26, and hemoglobin of 10. So this is the X-ray. Can anybody comment on both the X-ray, what you are seeing? Can you describe the X-ray? Because this you have been seeing. So ultrasound, I will tell you. X-ray, you have to tell me. First X-ray, what you notice in X-ray, and second X-ray, what you. Can anybody unmute and tell me? Sorry? See, you have to look at the X-ray, tell the finding of X-ray, and you have to tell me what stage of Bell staging you want to put this. X-ray, normal X-ray, we have put an X-ray over here. You tell me first, you tell me NEC is there, not there. Are you suspecting NEC? I'm not even asking. Sorry?
Suspect
NEC. Okay, you're suspecting NEC. That means what are the features of NEC in X-ray? You will have dilated bowel loops. You will have pneumatosis intestinalis. You will have portal venous gas, correct? And sluggish bowel movement, where you have to take a serial X-ray. So I've marked something over here. So you're telling there is X-ray, suspected NEC. So you want to put stage it in which stage you want to put this one with Bell staging?
Stage 1.
Stage 1. So what is your line of management now when you notice this in a baby?
Keep nil by mouth.
Nil by mouth. So you are convinced with X-ray that this is a suspected NEC, stage 1 Bell's, according to Bell stage, it is stage 1. And you are withholding the feeds, correct?
Yes.
Okay. All right. But you are not convinced with intestinal dilatation.
Intestinal dilatation is there.
So where you want to put 1A, 1B, 2A with Bell staging?
We'll have to put 1B.
1B. That means suspected NEC. But see here in normal or intestinal dilatation, mild ileus. So all right. So now let us do ultrasound. Okay. Ready? Okay. So now you tell me the bowel loops. Are you seeing any pneumatosis intestinalis? Are you seeing any color Doppler pattern of circular Y pattern or anything?
This is normal. Normal
exactly.
color.
Yeah. So in X-ray you got deceived. So what you will do now?
This is not NEC.
Please restart feeding with good tolerance. Now case number 2, 25-weeker with gestation of 29, corrected gestation of 29 weeks, abdominal distension, coffee brown aspirate, stable hemodynamics, total count of 13,900, platelet of 84,000, no bacteremia. You get an X-ray done. Now can anybody describe what the X-ray now? And you have to tell me what stage of bells you're going to put this, because this is how you manage in an ICU, correct? So please tell me, can you read the X-ray now? It's an abdominal X-ray. Then what you're noticing? You can unmute and tell me. It's okay. It can't be any alien thing. We are discussing about NEC only. So you have to tell me first, NEC there, not there. NEC is there, not there. Sorry?
NEC is there.
NEC is there. Okay. So are you seeing dilated bowel loops?
Mildly dilated.
So you are confused, correct?
Yes, sir.
Okay.
But there is a free air.
Free air is there. Okay.
So also suspected portal venous shadow is there, sir.
Portal venous gas, suspected portal venous gas. So you want to put it on what stage of bell staging?
So now that there is free air, it will come to 3B directly, sir.
Where you are finding free air?
Just below the right of the diaphragm. It's actually seen under both the domes of diaphragm, but will take more cognizance to the right side, sir.
You are telling this here.
Sir.
But my picture is clear, right? I am not seeing any area.
Air in the stomach area is there.
That will be there now. So this is your tube, feeding tube, which is placed in the stomach. So that will be there. Air will be there in the stomach.
And one linear portal venous shadow is there, sir, gas shadow.
Where? Over the liver, you are telling?
Yes, sir.
Where?
It's going in the oblique direction.
Here?
Yes, sir, this one.
This one?
Yes, sir.
But actually, it is very difficult to say anything about this. All right, no problem. We'll take. So, what stage you want to put in now?
So now that we are not considering air in the dome or diaphragm and considering portal venous shadow, it will be 2B, sir.
2B. So let us do an ultrasound and see. Okay. What you are seeing in ultrasound? See, this is the probe where you have put. Okay.
Yes.
Again. This is your layer of abdomen. This particular layer of abdomen. Then you start noticing free fluid, septi. Then sluggish bowel movement. Can anybody tell me? Yeah. This is jejunum or ileum, this particular one?
Jejunum.
Jejunum, very good. So there is sluggish bowel movement, there is free fluid, there is septation. And now let us do a colored. With this color Doppler, what do you feel?
White shape.
Which is abnormal, correct?
Sir.
You agree?
Yes, sir.
Here I've given one more slide of a normal looking bowel. So this is jejunum or ileum?
Jejunum.
This one, which I marked, you can see this layer.
That is ileum. Yeah.
This is your stool versus pneumatosis, intestinal lysis, how it looks. Can you make out the difference?
Yes.
So this particular case is almost you have to call your surgeon. Free fluid is there, X-ray is there. So in X-ray, it is very, very difficult. Half of you said it dilated bowel loop, suspected NEC. Few of them said I'm seeing a portal venous gas over there. So that confusion will always be there. So if you do an ultrasound abdomen, and look for the signs of NEC in ultrasound abdomen. You will not miss. You will have an accurate diagnosis, and your understanding will be better in terms of managing the case. Plus, you'll be helping the pediatric surgeon to take up for surgery or not. So we'll go to the next case number 3. 23 weeks, corrected gestation of 25 weeks, conventional ventilation, distension, gram-negative sepsis for CLEPS, which is confirmed, platelet and hemodynamics. Now let us go to the X-ray. Yeah. Can anybody describe the X-ray? First we'll start with this X-ray. Describe this X-ray, and then we'll go with your lateral X-ray. First, you describe the first one, AP view. There are only few signs in X-ray. You don't have to think so much. Dilated bowel loop, gas.
Positive of the bowel gas. Positive bowel gas, free fluid.
Okay.
So I cannot see any perforation.
All right. So what is your impression? What do you want to do with this baby? There is sepsis, Klebsiella, which is growing. So you are telling suspected NEC. NEC is also there. So you want to go with NEC plus medical management, NEC plus surgical management, septic ileus, or what do you want to do?
NEC plus surgical management.
So you want to go with surgical management because you are feeling that there is perforation.
Risk of perforation. Risk of perforation is high.
Risk of perforation is high. All right. So come, let's do an ultrasound and we'll see. I'm showing you the gas, portal gas, hepatic vein gas. 1 minute. I'll show this also. Can you see the sluggish bowel movement and encysted fluid is there in this particular first thing? And another thing, you can see sluggish movement. You can see the sluggish movement in the second picture. I've put Doppler also in the first one. So this particular pattern, color Doppler, normal, abnormal?
Abnormal.
Abnormal, sir.
Yeah. So in second picture also, if you play again, you can see encysted fluid is there. In second picture, 1 second. So this particular thing, jejunum or ileum? I'll play it again. 1 minute. I'll play it again. This is your again encysted thing, sluggish bowel wall movement, your exudative fluid, which is there. 1 second, there is the pen. This part is your jejunum. Differentiate now, right? Colon, your ileum versus jejunum. So grossly abnormal and ischemic bowel, no peristalsis, encysted air, thinning of the descending colon, walls with sloughed mucosa. So you have to go for surgery. So with X-ray, still there was a confusion how to go about it because you didn't get a real-time picture of health status of the intestinal bowel wall. With ultrasound, you're very clear. Now 4 weeks, 26 weeks, 33 weeks, corrected date on CPAP, recurrent apnea, intubated, antibiotic, CRP of less than 1. Can anybody tell me what I'm trying to show? Your air has entered into the hepatic system. You have your portal venous gas, hepatic venal thing, and even you can see bubbles here moving also. So unless you are blind, you will not miss this. Your entire liver is lighted up. Can you make out? with X-ray, it's literally difficult to find. And it's very subjective. One person will feel that it is there, another person will feel it is not there. With ultrasound, it is not subjective. It is there, not there. All right. I hope I'm able to convince that how an ultrasound can change your whole perspective of understanding of the stages, management of NEC, and it is very easy. You have very specific features which will help you in understanding your pathogenesis, what is happening with your baby, very clear. So now, thank you very much. So we had a few things which we wanted to show you last time. So this time we will show. Dinakar sir, would you like to add anything to this, sir? Dinakar sir? Before that, Kamal sir?
Yes, sir.
Would you like to comment anything, sir? We'll go with hands-on now.
Very clear. This, especially, we thought air when you look at through the ultrasound probe, we thought it will be looking like, I mean, like in the X-ray, we see air as colorless. Air in ultrasound looks hyperechoic. That makes things totally different. Perception totally different. So very excellent class, sir. Just one doubt I had. You said
Yes.
something reverb post echoic reverberation. What is that, sir?
That is the artifact, sir. Suppose, one second, sir, I'll show you. Yeah.
No.
1 second, sir. So that is the because of the air, it reflects, gives that reflection below the that particular air, sir. I'll show you one picture, then you will understand it better, sir.
Almost.
1 second. Yeah, can you?
Prashant?
Yes, sir. Yes, sir. Yeah. Yes, sir. Yes, sir. So.
Yeah, Prashant.
Yes, sir. This is your impression, sir. Where when ultrasound waves hit here, you can see the reverberation or reflection artifact with your pneumatosis intestinalis. Yes, sir. Over to you, sir.
Yeah. So now we are going to show you. Call that post technique. Camera. Once it's ready, you tell. ಬರಲಿ ಇದನ್ನ ನಾನು ತೋರಿಸ್ತಾ ಇದ್ದೀನಿ ಕ್ಲೀನ್ ಆಗಿ ಎಟ್ಲ ಅದೇ ಕ್ಯಾಮ್ರಾ ಹತ್ರ ಇಟ್ಕೋಬೇಕು ನೋಡ್ಕೊಂಡು ಅಲರ್ಟ್ಸ್ಬಾರ್ದು. See, now I am going to show you people. Prashant, can you hear me?
Yes, sir. Yes, sir. Go ahead, sir.
Yeah. So Dr. Prashant has told the previous class about internal cerebral vein. How to detect before the IVH develops, venous IVH develops. If it is an extreme premature baby, because of small fluctuations in the thorax. So how it looks like. Number one, I am going to show you the normal wave pattern. Sister, whenever I tell you should bring that wave. Okay, I am planning to show how to see the internal cerebral vein. Number one, first I am taking the probe probe I am taking, and I am keeping on the anterior AF. I am trying to keep the AF. Okay, you people can see very clearly. You people can see the very clearly the brain. Slowly switch on the color Doppler first. See the beauty. What I did is, the beauty in this is, see 3. I kept the scale as in 3. So I'll put the CPA color. See, it has gone to the pulse repetition frequency has come down to less than 1. See the how color looks like. Just I am showing you people. So ready? See, in pulse repetition frequency, if it is very, very small, see, I can see the internal cerebral vein very clearly. Suppose if I'll the same thing, if I am putting the color, you can see the how the blood vessel, internal cerebral vein, it is coming and forming to the straight sinus. See, you people can see. Yeah. So this is the vein where I am showing you people. Is very, very important. So put the pulse Doppler, put on this. Hear the sound, humming sound. This is the wave you are going to see, continuous wave. And there is no curtains like last time Prashant has told. So if it is a curtains, what you mean by curtains? Okay. If it is a curtain, what you mean by curtain? See my hand like this. Once again, like this, like a pulse. If you can see the pulse, like there is grade Z. This is grade 0, 1, 2, 3, 4. There are 4 grades are there. What Prashant Gowda has showed you people. If that grade, Prashant, if you have, you can show them right now.
Yes, sir. Yes, sir. Yes, sir. I'm showing, sir.
Okay. If it is grade 3 and 4, more chances of hemorrhage. This is called internal cerebral vein reading. See, this is a continuous. There is no chance. I told my sister to bring one more baby, premature baby. I will show you. Please see this slide. What Prashant is showing you. First one is like this. Second one is minimal curtain. Third one is almost it is 30. The baseline. The fourth last one is falsified pattern like this. So 3 and 4 are more prone for IVH. So you can detect if it is extreme premature baby if you put on ventilator. Indirectly it will tell you whether this baby will develop IVH or not. Okay, number 1, that's what I want. Okay, number 1. I will show you one more baby. Hold on. Ma, can you keep the baby here? Yeah. I am showing you more smaller baby. Prashant, can you switch off your presentation?
Yes, sir.
Can you make my presentation bigger?
Yes, sir. Yes, sir. If you speak, it will come, sir. No problem.
Huh?
Yes, sir. Yes, sir. Yes, sir.
Can you make my presentation bigger?
It's coming, sir. It's coming.
Okay. Don't see the above one. The below one is very good. That is called internal cerebral vein. Put a pulse Doppler here. Almost this is also a continuous type. So there is no chance of IVH for these babies because this is now 4th day baby. So if it is any pulsatile like, more chances. If it is an extreme premature baby, you just put on the ventilator. You see for these babies, because of not only thoracic pressure reflection, if it is a grade 3, you can yourself check it after putting on the ventilator whether there is a grade 3, grade 4 pulsatile pattern is there or not. Even with the minimal setting, then within 1 to 2 hours, those babies will develop IVH. So if there is a PDA, big PDA, you see the internal cerebral vein fluctuations. It is very, very evident. Why I am telling this all, there are so many things are there. Our brain doesn't know. So IC is not searching. This is one thing what Prashant has told me to tell you people. The second thing, come to the NEC, then biliary atresia, then malrotation. Now we will go to the malrotation first. I am taking the baby. Now I am going to show you people where to keep the probe. Whether this is not always 90-80% sensitivity predictive value is there. Please come dear. See, this is the baby. I am keeping this one on the xiphisternum placer. Okay, this marker is towards the right side. Marker is towards the right side. You people can see marker is towards the right side. Okay, I am keeping this. Can you show this thing? Okay, go to the neonate head, neonate, I mean abdomen. I changed it. See, this is the liver. This is the stomach. Baby has been fed. So this one down. You people can see something is pulsatile here. Okay, it's very clear. I am coming down. You can see abdominal aorta now, just above the vertebra, abdominal aorta. You can see just above the abdominal aorta. Please follow me. Follow me. Just I told you above the abdominal aorta. Very good. Don't shake. Very good. See, just abdominal, above the abdominal aorta. I am planning to show you people. See, there is something called, you please follow it. See, it is celiac artery is going to the hepatic artery and gastric artery. You can see it is dividing. It is dividing. Just I'll go up, you will see round one. I am coming down slowly, it is dividing. That is called celiac artery. You people can see. Then what you are seeing is this one. See now, you people, this is the beauty how to diagnose. Please, dear friends, follow my cursor right now. when I told this is aorta, this is vertebra, this is the one where you are seeing SMA, superior mesenteric artery. How to diagnose SMA? Just above the aorta, mesentery is nothing but a fat layer is covering the superior mesenteric artery. That's how we are going to diagnose. Whitish thing is covering. This is almost left side of the abdominal aorta. Almost it is the left side. So SMA is towards the left side. So this is inferior vena cava. This one from just above the SMA, you are seeing the, what is that? What is this artery? What is this vein and coming and forming? So how portal vein is forming? Portal vein is formed by two veins joining. Which one is this? Follow this. See, once again I am showing you. See now, abdominal aorta is pulsating, something just above the abdominal aorta. You can see whitish. See like this now. Now, yes, beauty. Superior mesenteric artery you have seen. SMA you are seeing. Splenic vein. Splenic vein is joining the portal vein. Okay, to form a portal vein. See this. This is the one I want. Abdominal aorta coming to the SMA. This is the towards the portal vein. Portal vein is towards the, this is inferior vena cava. Portal vein is towards the right side. So SM almost malrotation is ruled out. That is the way we can diagnose what is the problem. Okay, number one is over. Number two, see here, this is more beautiful. Okay, you can see here more beautiful. Renal vein is joining the inferior vena cava just above the aorta. Renal vein is joining like this and to the this thing. I'll show you the renal vein is joining to the inferior vena cava. This is SMA. This is splenic vein. Though this is portal vein. Portal vein, splenic vein. So dear friends, malrotation is ruled out. 99.9% ruled out. Okay, then come to the biliary. Just now fed baby. I think so. I don't know whether we can see or not, but anyhow, see gallbladder also I can see very clearly. So Prashant was telling about the SMA. I'll show you. I'll go to the gallbladder later. See, what is this? You people can see. Anybody can tell me? Anybody can tell me what is this? Aorta.
It is aorta with superior celiac axis and superior mesenteric artery.
Yes, boss. Beautiful boss. So you can see the aorta. You can see the celiac artery is dividing into the two branches. Below one is called a SMA. The diameter, how to see from here? It should not be more than 2.7 to 3.7. It should not be less than that. It is less than 2.7. So it is normal. There is no NEC. Then come to the SMA flow. Come to the SMA flow. How to do the SMA flow? Put the pulse wave Doppler and decrease the gate. It's very clearly, anybody can tell it is sir, it is SMA sir, it is easy sir, what you are showing. And always try to make it an angle. That is important. It should not be more than 80 centimeter. Suppose there is a PDA, this one will reverse. That is called absent diastolic flow or reversal flow. So this is exactly almost 60 to 70 centimeter. If it is more than 120 centimeter per second or more than 80 it is going, that means baby is going for NEC. See, the maximum is almost around 60 to 80. If it is more than 80 to 100, that means hyperemic flow. If it is more than 100, that means this baby is having hyperemic gut, probably going for NEC. Number 1 is over. You can focus. I think so. Can you people see the video? One more video from this thing. Dinakar, Prashant, can you go to the Dinakar one more video? Can you display that? Not this.
The video has to be on. Sir.
It is on.
Yeah. We can see the machine.
Not machine. There is one more Dinakar is there. There is one more Dinakar. Can you search?
1 minute. Sir, you can switch. You can mute this particular video where you are showing, and you can unmute one which you want to show. Automatically, it will come. Unmute that, sir, which you want to show video.
I am muting it.
Yeah. Unmute
so
the.
Can you see now? Can you switch on to
sir.
Dinakar one more?
Yes, sir.
Okay.
Yes, sir.
Can you see the video?
Yes, sir. Yes, sir.
Okay, you can see the video. 1 minute.
So you unmute. Now, you can unmute the Dinakar guest is there now, sir. You can unmute that. Which video you want? Mobiles you unmute. Yeah, you can speak now, sir. So voice is not coming. This video voice is not coming, sir.
Can you see now? Can you hear me?
Yes, sir. I can hear you, sir. Yes, sir. Okay, sir. Oh. You can do.
Okay. See now, dear friends, you have to know one thing very clear. See, this is the place where UVC will always come and stick. See here, stuck. Sorry. See, this is the IVC. This is the one you people can see the IVC. Video is not seeing, huh? Come here, dear friend. Can I show you this? No problem. Okay, Marco. Prashant, can you see now video in this?
Yes, sir. The ultrasound video we can see, sir, now.
Yeah. See, this is the place Prashant was telling you people, dear friends.
Yeah.
See, in my cursor, you can see my cursor very clearly. This is right hepatic vein. This is the inferior vena cava. See, you people can see here, there is something like. So this is the place where ductus venosus is there from here to here. From here to here, this is the ductus venosus. What happens? This when you are pushing, usually what happens? It will start going to this place. This will start going to this place. See, please once again follow.
Not able to see, sir.
Can you see now? Can you see the video?
We can see, sir.
No, sir.
We can see that ultrasound video, sir. Image we can see.
Yeah. See, this is the place where I am telling you is inferior vena cava. This is the place where ductus venosus is there. Usually when you push the UVC, see, this is the place it will go unstuck. I'll show you where. See, you can see this place. This is the place. This is called a pouch. See, can you see this now? It will come and stick here, and you will be searching where it has gone, why it is not able to see. See, this is the place. Very clear.
He has to keep the camera little away. We can see only one part of image. Yes. We can see now. We can see now.
Okay. No. Yeah, when you are pushing, it will come here. From here, this is the place where ductus venosus is there. What happens is, it will go like this, and it will stuck here. Then you will see where it is there, After one day, liver will have a complete infarction, or it is extravasation in the liver. So that is the reason when you are pushing, after putting the UVC of 4 centimeter, you have to push the liver towards the left. When you are pushing the liver, lower border of the liver to the left, this artery will come directly in alliance with the ductus venosus. Then it will go to the inferior vena cava. So minimal push, not maximum push. If you will do the maximum push, it will go to the left hepatic vein. So this is the place where I am telling you people, please see this. See, it will go here. Okay, please, whoever they're attending, see, dear friends, and learn. Okay, see, what you are seeing here is gallbladder. This is the gallbladder. Can you see the gallbladder? Is having, once again, gut signature like white and black. See here, it's a typical gallbladder. Mucosa, submucosa, this is white, black, then white, then black, then white. All the layers we can see in this. Once again, let me show you. See, you people can see this. Because baby has been fed, that is the reason you are seeing like this. Yeah. Biliary atresia, we can take in other class, but it is too deep for the neonatologist. But once you learn the basics, it's good. Okay, this is very important. That is called biliary layers. If you are seeing the biliary layers, you can see biliary sludging movement inside it, and I am putting the color. You can see the vein, nothing is there. See the layers of the biliary. I'll put it more focus on this. Now we will go to the gut. First, before that, somebody was asking me, sir, how I will see PVG? PVG means portal venous gases. It is in X-ray, it is really difficult. Put from the right lateral position. This is called a right lat. This is the right side of the liver. I am cutting this. I'm putting the probe like this. See now the liver. You can see the gallbladder. And how to detect hepatic vein and portal vein, all those things you can take another class because it is too deep. So suppose if you are having NEC, Please, dear friends, put it on the left lateral position. You can see very clear. Very clear. You can see all these places, white dots. It is connected in the periportal veins. Peri means peripheral, means superior. Portal veins. That gas means in ultrasound it is white. It will collect very clearly. It will collect. Okay, so that is called PVG. Now come to the intestine. This baby is healthy. This baby doesn't have any NEC or something like that, or bowel wall thickness. But I'll try to show what you mean by gut signature. I am not at, see, urinary bladder is full. Anytime baby will do susu now. Okay. You people can see the liver. This is liver, and I'm see. Can you see now? This is the gut. One gut I am able to see, and you are able to see inside the gut there is a stool, and the layer of the gut also you can see. Mucosa, submucosa is black. Okay. Mucosa I can see, submucosa I can see. I can see the muscularis is black. I can see serosa is white. This is called clear-cut gut signature. In between the mucosa and submucosa, there is a white layer. If you can see, it's not here. That is called PI, nematosis intestinalis. Here, what we are seeing inside the lumen, we can see the stool as well as the gas. You people can see so many intestines, all the layers. Here, you can take one layer and see the measurement. It should not be more than 2.7 millimeter. This is a kidney. Just above is it's an intestine. See one intestine cat and just follow the other intestines. Follow the other intestines. Now you can see inside this intestine, peristalsis is there. Inside the intestine, stool is moving, food particle is moving. You can see this. So very good peristalsis. More than 9 peristalsis or 12 peristalsis is good. If the peristalsis is very minimal, that you cannot detect in the X-ray, so you can see all the layers. I don't think anybody can live, they can show so much, all the layers of the intestines. If there is a NEC case, we can show all the other things and just put the color, then moone ಮಾಡಬಾರ್ದು. You cannot see more than 9 dots. You can see the blood flow in the intestine. See the other one, peristalsis. I'm tracking it. Ready? You tell me. It's the aorta. Yeah, it's ready. Okay, can you see one more video, Prashant? Can you see the video? I'm not telling you to the knobs. I am not telling you to see the nerves. Can you see something video other Dinakar?
Not it, sir. Not it, sir. It does not come yet. Video is not on.
Now
No, sir.
ultrasound is there. Ultrasound is coming.
No. That is stopped now.
That is stopped now.
Yes, sir.
So I will take the high frequency probe. I will take the high frequency probe. ಏನು ಉಸಿರಾಡ್ತೀಯ ಅಷ್ಟೊಂದು? ಏನ್ ಬಂತು ಸರ್? Now I'll show more crisp, clear. Okay, crisp, clear things. See, you people can see the intestines movement. Can you people see the intestinal movement and layers of the intestine?
Yes, sir. Yes, sir. Sheikh, clear what's there. The video clarity is not that clear, sir. He has kept too near and is. Yeah, little far he has to keep, sir. Yeah. Yes. And not to move. Don't move the hand. Yeah, this is better. Yes, sir.
So from right iliac fossa, I am going towards the left iliac fossa. I am showing you the signs. Now can you see all the intestines now? This is all the intestines what you are able to see. If I put the color, it will come like this.
Clarity lala. Huh? No, it's clear. You better. Where is the color?
With so many intestines, can you people see movements? So you have to take a linear probe or a curvy linear probe, what you are using for the brain scanning or abdominal scanning, that you can see. So now I showed you the SMA and mal rotation and NEC, how to diagnose. NEC here it is not there, so I'm not able to show you people. Okay, see this is a full bladder, and you can see the intestines movement. You can see the intestinal movement. So this is a healthy gut. One more internal cerebral vein I told you. SMA I told you. Biliary atresia is a other class, but one thing you have seen the gallbladder minimum is it should be 1.8 centimeter. 1.8. It should be at least minimum 1.8 centimeter. If it is less than that, if it is it is abnormal, you are not able to see all the layers of the bile duct. That means it is a suspicion of biliary atresia. I showed you all the layers also of the gallbladder. Then I showed you intestinal layers. Then PVG is not here. SMA we showed. That's it. Almost NEC is also done. Then Prashant, what is the previous class you have taken? about the IVH and measurements.
Yes, sir. Yes, sir.
And one IVH and the measurements.
Yes, sir.
See, can you see in other video, Prashant? Can you see in other video now? I am going to display now.
Not. It has not come yet, sir.
No, just check it, Dinakar. One
no.
more Dinakar.
No, sir.
Slowly. And Prashant was asking me, sir, can you show me the brain signature? That day I showed you what is white and black, white and black. Can you see now, Brian?
No, sir. No, sir. Video is not seen.
Dinakar,
No, sir. Not seen. Only voice is heard.
no, can you project that one big? Make it big. Make it big. Prashant, can you see Dinakar? One more Dinakar, Prithviraj. Is it
No,
logged
sir.
in?
No, sir. Video. You can't see the video. Yeah. You can see the video now. Yes, this video we can see.
Okay. See now, I am going and showing you the bride. See, there is called Davis index. In the Davis index, first one is occipital. Thing is very important. This is the way occipital you are going to see it from here, anterior to this. It should not be any time more than 26 millimeter. It is here almost 11 millimeter. So if it is more than 26 millimeter, that means occipital horn is enlarged. Why occipital horn is enlarged? Whether it is a hemorrhage, whether it is colpocephaly, that means where you will get colpocephaly, usually corpus callosum, agenesis you are going to get. Then come to the one more view called coronal view. Coronal view taking it should be center, it should be exactly center and properly placed. See, I am able to see the third ventricle very clear. Both the lateral ventricle I am able to see it very clear. Okay. Freeze it. What is the criteria to measure in the Davis index? You are supposed to see the third ventricle very clearly. This is the third ventricle I am able to see. This is the lateral ventricle. This is foramen Monro. So now take the measurement from here to here. Lateral ventricle. It should not be more than 4 millimeter. Here it is not even 2 millimeter. It's not even 2 millimeter. That means ventricle is not enlarged. This is number one. Number two, third ventricle you can measure either here or in the one more view. Which is the one more view? Anybody can tell me what is the one more view? This should not be, third ventricle should not be more than 3 millimeter. This is also not more than 1 millimeter. Okay, in where is the third ventricle you can measure? Other view? Third ventricle?
Sagittal.
Sagittal? No, madam. Sagittal you cannot measure because third ventricle will be abnormal in the abnormal means it is an something abnormal shape, not like this. Because in that you know that isthmus will come inside it. Okay, where thalamus adhesion will come, massa intermedia will come. See how you are going. I'll show you sagittal view. I'll show you sagittal view. So this is sagittal view. How you are going to measure? See proper. I'm showing you people. Tell me how you are going to measure. This is this way. How you are going to measure? This is the third ventricle. How you are going to measure if this is a third ventricle? You cannot measure. This is the fourth ventricle. You cannot measure fourth ventricle in the sagittal view. That is the reason. Please concentrate. That is the reason I am telling. Third ventricle should be. See, this is where I am putting the probe. Just see where I am putting the probe. Behind the ears. What is that view called as? Is it a temporal window or mastoid window? See this? Anybody can tell me? See, I am very clear in my views. So I am going towards the posterior. Okay. This is whatever I am seeing. This is cerebellum. This is cerebellum. This is the cerebral peduncle. So where is the third ventricle? If this is an anterior, where is the third ventricle? We are feeding each other. See now, tell me where is the third ventricle, anybody? So now I am putting into the this view. Temporal window. In temporal window, where you are going to see? No. See, even from here, I can see the lateral ventricle. I can see both the lateral ventricle. And if I am coming down, I can see the third ventricle. Where is my finger is? Okay, this is called a mastoid window. Either from the mastoid window or temporal window is the two windows where you can measure the third and fourth ventricle. See, I'm measuring it. Okay, see, I'll take the other baby if you want. See, yourself, you have to tell me. It is a more smallest baby. Not in the sagittal window. Remember, dear friends. ಹಂಗೆ ಎಲ್ಲ ಆಡ್ಸ್ಬಿಡ. I think so. This is a very good view where you can see. So very small, I think so. So even fourth ventricle is very small. Okay. So both where we have to see the fourth ventricle and third ventricle, usually mastoid or temporal window. Number one. Number two is what else you people wants to see either in the brain or abdomen. Anybody can ask me question. I'll try to show you people. Anybody can ask me any question. Any questions you want to ask? Prashant?
Yes, sir. That's what, if audience have any question, they can ask us.
Sister?
Hello.
Yeah, you can take the baby. You can take the baby, clean it properly. This also clean it properly. Because that gel is a condensed water. Staphylococcus will come. Yeah, any doubts, dear friends, you can ask me. Yeah, over to Prashant.
Come on, sir. Yes, sir. Over to you, sir.
Thank you, sir. Very informative class today. Excellent of the signature of the gut and the brain. After that, by Dr. Denakar, sir. I think our students are very gifted. Lucky few. We were also not, taught like this during our training. So I think our students are a bit lucky compared to that. Though we are all very worried that we are not able to have formal hands-on training on echo and ultrasound. At least we have got this virtual trainings which are happening, and almost everyone can attend from wherever they are. Even if they are in isolation ward in COVID posting, also they can attend. So that's a benefit of having it virtual. And I should thank Denakar sir and Prashant sir for their real dedication. They have this penchant for taking classes, and they are untiring. See, it's become 4. I am also became restless, but they are still ready to teach. So wonderful, sir. Excellent. You are giving us motivation how a teacher should be. Thank you, sir. Thank you so much. And I think this was an excellent class. And we'll be meeting again on Tuesday, sir, this time.
Yes, sir. Yes, sir. We'll be taking class on septic arthritis and dysplasia hip and dislocation.
That is the, I think so. That is one class, sir. Then next Friday will be the last class of lung ultrasound. Then I think so. All the classes about the brain and abdomen and these things, everything is over. Only thing, students should train themselves. If any doubt is there, anything, they can reach me in the WhatsApp, and they can take a photo. They can ask me anytime, what is that? What is this? Anytime, because so many people are asking me, putting in the WhatsApp group, sir, in the midnight also. Sir, what is this? I will definitely guide them, sir.
Thank you, sir. Thank you, sir. Thank you so much. And I think after the end of the class, we can have the session. We can have those videos. We can share it.
Yes, sir. Yes, sir. Yes, sir.
Yeah.
I'll give it to you, sir.
Thank you so much, sir.
We'll send it,
Yes.
sir. Yes, sir. Thank you. Thank you.